psychiatrist. He's the director of the Benham Hospital in Cairo. And he's also president-elect of the World Federation for Mental Health, and chairman of and he has been chairman of the Middle Eastern Division of the Royal College of Psychiatrists. Nasser, do you want to just say a bit more about yourself?
Thank you, Trudi. Yes, well, thank you very much for having us on this amazing webinar today. The college has always been supportive of World Mental Health Day. And I'm not sure if I'm here as a psychiatrist or I'm here talking on behalf of the World Federation for Mental Health, which some of you may know, chooses the topic of World Mental Health Day every year. The Federation was set up in 1948 in London, in fact, and has worked very closely with WHO organizations. And so last year, the topic of suicide was a huge success. This year, it's, greater advocacy, greater investment, and reaching a larger group of people, really greater access, is also a very pertinent one. But the last thing I want to tell you about myself is that I'm also here as someone who's suffered COVID-19 pneumonia and ended up in hospital in intensive care back in March, when the community anxiety about the virus was at its maximum. So I guess I'll talk a bit about each one of those. Yeah.
Wonderful, thank you. And next we've got Dr. Catherine Tiango Mutisya, who is the Vice Chair of the Royal College of Psychiatrists African Division. She has been a consultant psychiatrist at the Mathari National Teaching Hospital there. She is also very well known in the public mental health world and was listed as one of the top 40 women in the Business Daily back in 2010 and 14. So she probably wouldn't tell you that about herself. So Catherine, do you want to say a little bit more about just who you are, and then we'll go on to the conversation.
Yes, good afternoon, everyone. And I'm here to represent the African Division perspective as to how we fared with the COVID-19. And it's great pleasure to be with you. Thank you.
Thank you, Catherine. And then moving into back to the UK, and we've got Elaine Lockhart from Glasgow. So Elaine has worked as a consultant in pediatric liaison psychiatry at the Royal Children's Hospital in Glasgow since 2001. She has also been the chair of the RC Psych in Scotland Child and Adolescent Faculty since 2016. Elaine, do you want to say a little bit more about yourself?
Yeah, good afternoon. Thank you so much. It's an honor to be here. So I'm working in the Children's Hospital in liaison psychiatry. So I guess my main passions are thinking about physical and mental health together. And then also my role with RC Psych in Scotland, thinking about how we could really do with improving and investing in children, young people's mental health, and in particular in special services. And also looking forward to hearing about people's experience of COVID-19 in their countries, although sorry to hear that Nasser's had such a personal experience of COVID-19, but I thought it would be good to have a think about how it's had an effect on all of us. So thank you.
That's brilliant. Thank you, Elaine. And just to say, I'm Trudi Seneviratne. I'm a general adult and a perinatal psychiatrist, and I'm the registrar at the Royal College of Psychiatrists. I work in a very busy mental health trust, South London and Maudsley in South London. So I'll share some of those experiences. So what we wanted to discuss really, and we'll go around each of us thinking about a couple of questions really related to the pandemic and mental health. And the questions we have for ourselves and for you listening out there as well, is how did the pandemic affect us personally, affect each of you and each of us personally, and perhaps to think about the changes to mental health and our mental health during lockdown. And we can share whatever we want to share with us as long as we feel comfortable. And then also to think about how the pandemic affected the community around us and the mental health of the community around us, and perhaps what were the significant changes we saw around us. So those are huge questions, and we probably won't get through all of it in an hour, but perhaps just to sort of think through some of those areas. And so shall I start? We agreed that I was going to kick off and say something about perhaps the experience that I had and working in South London. So perhaps the first thing to raise, and Nasser said that COVID affected him, I think the most significant thing, or one of the significant things for me, is that COVID actually hit me very, very early, even before lockdown happened in the UK. And it was a real shock, actually, because I work clinically in a busy psychiatric mother and baby unit service. We were hearing about the pandemic sort of spreading across the world, and but I guess sort of from the government perspective, things hadn't really gone into lockdown yet. In fact, it went into lockdown, I think, about 3 weeks after I was hit with COVID. And I'm a fit, healthy person generally, and have fortunately had good health. And I was really quite shocked because it hit me very quickly. I was in the middle of a meeting and became rapidly sort of breathless. And almost had a panic attack, actually. It was really quite shocking because I just didn't know what it was, because rapidly became very, very breathless, didn't know what was going on. Immediately thought, gosh, what is this? Never had asthma in my life. And then from that, it then progressed onto a temperature and, a whole range of the COVID symptoms that we all know about. As I said, the country hadn't gone into lockdown at that point. I have 2 young children, teenagers who were at school. So immediately we had to, there was no way of getting testing, which was a real challenge at that point. And the testing, although it's improved, was still really not very good. Fortunately, I didn't need to go into hospital, but I did have probably about 2 months off work, which is the longest I've ever had in my entire career, actually. I've never had 2 months off work for anything in my whole life because, fortunately, not been unwell. So that was a real shock. And apart from sort of fear on the one hand, because, as the country then went into lockdown, there was an awful lot of information, wasn't there? So I genuinely experienced anxiety for the first time in my life and a sense of panic, but a real worry about, my goodness, what is going to happen. The impact on less me, but sort of as a mother, I worried about the unit, the work, the family, everything. It was really, really quite a terrifying time. What I then discovered was that the unit that I look after, there was a spate of infections that happened across both staff and patients and babies. So sort of almost simultaneously, at the same time, or subsequently afterwards. Reflections moving forwards is that I guess I remained in a state of, the anxiety improved because I realized I wasn't fortunately going to get any sicker. But I guess, we talk about the pandemic causing generalized anxiety, there's a general swell of anxiety in the whole population. And watching that both, for me personally, but also for my children who I could see were getting anxious. And then when I was able to return to work, the sort of, supporting the staff and the patients, I've witnessed, in my clinical area, a number of women who, were admitted. Well, there was a real fear of people wanting to come into hospital because they didn't want to catch COVID. So even, very ill women who would normally perhaps, the UK is very lucky. We've got psychiatric mother and baby units, and they're usually all completely full. And women just didn't want to come in. They were fearful. Those that did come in were generally very psychotic, very ill, a number of delusions related to COVID, thinking that they were responsible for COVID in some way. So it's been an extraordinary time, actually. Things have settled down. Women having antenatal care, but not being able to take their partners along for antenatal care with them, having to give birth in isolation. And as the months have evolved, we've seen issues like isolation for people not being able to have the support when they've had a new baby that they might have had, not being able to access their usual healthcare processes that they might have done. And then also issues of, the stress of issues like domestic violence when that's happening, and people can't reach out to the usual helplines that they might have, might have been able to reach. And I guess issues of, of domestic violence impacting the children at home is something I've also had to deal with. And, some families where there've been increased rates of alcohol use within the household, and we've all seen, haven't we, across the world around perhaps increased use of alcohol during this time. So many issues and on so many levels. And I might just pause there because there are, we've got a Scottish experience as well, but I think, we're in the UK, we're sort of in the beginning of a possible sort of second wave. We're sort of back where we were back in January, February time, and come March certainly in England, there was a big bump of deaths and illness from COVID. So I think generally across the health system, and I'm looking around at professionals and patients and the educational system, people are worried, they're not quite sure what's happening. There are different rules in different parts of the country around whether you can go out, how many people you can and can't see. We're back into not a complete lockdown where I happen to live, which is in South London, but certainly people are restricting their movements. I think, and perhaps the last thing to say is that I know, for example, the college, and it was so wonderful to hear that Adrian James, our president, is at the college today. So he was joining a meeting from the college, but actually the Royal College of Psychiatrists, and they, one of the building that sits in Prescott Street in East London is currently closed. Well, there are not completely closed. There are some staff going in to maintain it, but that's really odd. But we're having to sort of cope with that too. Okay, I'm going to pause there. And Nasser, do you want to take over and tell us a bit about what's happened in Egypt and for you? I think it says Nasser is offline. There's been a technical glitch. So shall we move on to Catherine and see if Nasser can come back in? Catherine, do you want to tell us about what's happening in Kenya?
Yes, I work in Nairobi, Kenya, East Africa, and I wasn't personally affected directly suffering from COVID, but emotionally it did affect me. In Nairobi, the first case was declared on the 12th of March, one day after the World Health Organization had declared it as a pandemic. And for us, we had just completed writing up we had a task force. I was a member of the task force on mental health. We were just finalizing, and I was actually to start leave, but that had to be cancelled because all the doctors were required back into the hospitals. And for me, personally, emotionally, I had my firstborn locked out of the country. And immediately I was resuming on 1st of April. We had a close family friend person, actually the pilot who flew the people from New York, and it became a reality that you could get COVID from work related. And I saw a close person I knew die, sadly. And for us in Africa, the fact that we were not sure how to condole with people who had lost loved ones, because it was still new for us, was the hardest bit, because here in Africa, people, whenever somebody dies, it's expected that the community gathers together and supports their loved ones. We also saw churches closed, and that affected many people here. And when it came to lockdown, we know there are many people who depend on daily work to earn a living. So we had people who were weighing, do they risk dying from COVID or do they risk going to work? So that was quite stressful. Overall, we noted that in terms of access to treatment, many people relied on the National Mental Hospital, which is Mathare National Teaching and Referral Hospital. And when the city, Nairobi City, was locked down, then people from the rural setup could not access treatment. So that was actually a glaring gap that we needed to decentralize mental health services. But overall, we saw increased rates of anxiety, increased rates of depression, and of course, increased use of substances. With the fact that in Kenya, internet penetration, as the other countries did telepsychiatry, the public sector was not able to do telepsychiatry because our patients are used in the public sector to go physically face-to-face. The private sector, people were able to do a bit of telemedicine. So eventually when the hospitals were opened, we had many people come in with still the anxiety of medical workers being prone to the disease. And I can see Dr. Loza is back. Probably he could take over. Yes, thank you.
Thank you, Catherine. Dr. Loza, Nasser, do you want to carry on, continue? Nice
Sure,
to see you back.
yes, well, yeah, I'm sorry, I sort of, it's the internet thing that seems to be working now. Anyway, essentially, yes, it's been a tremendous wave that has affected our communities. And like, you know, I was thinking a moment ago, listening to Catherine, I visited Mataria Hospital many years back. In the old days, we would visit hospitals or treatment centers in various parts of the world and think that we can compare clinical signs or findings and reach conclusions that people in Kenya versus people in London or in Egypt become well or unwell in different ways. Well, that was wrong, because there are many reasons why different people in different societies would channel somebody in the direction of mental health services. And when I think of this current pandemic, I think there are many reasons how and where and why people ended up with a diagnosis and various approaches to treatment. So I became unwell in early March. I was in the UK at the time, and there was no talk of lockdown or anything. But I guess psychiatry prepares us for this, and so does age. We become very good at denial. And so I was sure I didn't have the virus. Not me, how could it be? And I went on, and it wasn't that easy to get a test in the UK at the time. And then I flew back to Egypt and went to work until I collapsed completely, of course, with fever and all that. And the second thing that happened is that there was an idea in many countries, not necessarily all around the world, but it was like that in the NHS in the UK too, that only the National Health Service could treat corona, but you couldn't possibly go to a private hospital to treat a COVID. So I was unwell, and they told me I had to go to this National Health Hospital in Egypt, and I was ready to go. And they said, no, you can't go. You can't go by yourself. We have to take you there in an ambulance. I wasn't so bad, you see, but they insisted, and I obeyed the rules. So I get into this ambulance, and guess what? I have a police escort following me. Such was the panic of society that there's a positive case of COVID, one positive case, now he might abscond and go and infect the rest of the country. So let's send the police with him. So that kind of attitude reflects who's going to be channeled actually to the treatment centers. And I'm pleased to see that 6 months later, the world has, and certainly Egypt has, relaxed a lot about the panic situation that people have once there is a positive case. I spent about a fortnight in hospital, and wasn't the easiest, I have to admit. It's a very difficult experience to not be able to breathe. And it reflects obviously on our psychological state, and there's a lot of concern, one, for mental health of people who suffer from the virus. Another concern, of course, for the mental health of people, the workers and the nurses and the doctors who are working there. As it is in most places around the world, they worked on shifts. They didn't go home for 2 or 3 weeks on end because they had to have a test every time they come in. Very stressful life situation. And what I would really like to, having gone through this horrendous experience and asked to stay a whole month at home, as Catherine was saying and Trudi was saying earlier, it's, if there's one lesson to be learned from all that, is to include the service users, the families of people who have had a problem into the decision-making, the policy-making, And this is something that the World Federation for Mental Health really advocates for. We need to include the consumers, the service users, as part of the decision making. It's extremely valuable that individuals who suffer from the disorder can come and say, well, you know, this is how it should be done differently, and I would benefit a lot from that. You know, mental health campaigns, advocacy, the need for people with the virus and the support that they need is all something we're going to work for. So when we choose our topic of mental health day to day as greater access and greater investment, the access isn't just about policy. It isn't just about funding. It's also about the culture, the community, who decides who's going to go get mental health support before or after an infection of COVID-19. Mood disorders, and you know, are quite common. I went through my own mild depression after the infection. Now, who's going to be challenged to see a mental health professional? You know, often people working in intensive care units are not going to put mental health into their first number one priority. And it's our role to advocate for that, because there's a definite need for it. So I'm pleased to see that 6 months later, the attitudes have changed, but we need to do more, is the answer. Thank you.
Nasser, thank you so much. Shall we move on to Elaine from Glasgow?
Yeah, thank you very much. When the pandemic hit the UK, up in Scotland, because we're further north, it did seem that there was a bit of a delay for a few weeks. So it was a really odd time where Scotland was doing reasonably well, but we were seeing on the news every day about the wave of COVID-19 rolling across Europe and then hitting London. So in the first few weeks, when it was really becoming much more of an issue here, I think most of us just became really anxious, and it was that worry. So unlike both of you who've actually had COVID-19, I'm slightly alarmed to say that I became anxious every day that I might have it. I work in a children's hospital that's also linked with an adult hospital where all the cases for Glasgow were coming. So as a team, we were needing to share facilities, walk around the hospital, and before really having protective equipment, there was this concern that this invisible virus was there and any of us could get it, or we could bring it home to our families. So very luckily, children and young people weren't affected that badly with COVID-19 here in Scotland. It was mostly in the adult and the elderly. But we had to change our services very dramatically. And I think it was really impressive, actually. The NHS is a huge organisation. And within a week or two, we managed to do an overhaul of the service, you know, working out who we needed to see face to face. And we're very fortunate that we do have video or tele-psychiatry that's available to us. And we were able to work around that. But what we saw was that children, young people and families just weren't coming to hospital unless they were in absolute crisis or were already in hospital being really unwell. And as the lockdown continued, we began to see the fallout of that. So the most vulnerable children are the ones who have struggled, and families who were just about holding it together with children, for example, with learning disability or neurodevelopmental disorders, had lost school support from charities, support from social work, and that really kind of had a big impact on them. So I think we're in a very fortunate situation in Scotland, a part of the UK, in terms of the development of services. But what we really see, the hard end, is where there is social and health inequality. So the most vulnerable children and families were absolutely hit the hardest. And I guess if I think about how I'm feeling about it now, although personally I'm fortunate to be feeling fine, I have lots of worries about what's happening now and what's coming our way. We just know that we are storing up problems. We have lots of children, young people who are really vulnerable now. They're coming in acutely unwell with kind of severe psychosis and eating disorders. And we know family situations are very vulnerable. Some children are having to be looked after by other organizations. And I guess in some ways it feels a bit disconnected that as a health professional, we are so fortunate working and being well looked after. And there was a lot of focus on mental health and well-being for staff throughout the pandemic. But in the meantime, in our communities, we're in a partial lockdown again, and there's lots of worries about jobs and financial insecurity, and hearing about child poverty growing during 2020, which in the UK does seem quite remarkable, but there's just quite a lot coming our way. So I think we're still bracing ourselves for more to deal with.
Thank you so much, Elaine, for your experience, and thank you to Catherine and to Nasser as well. So a few questions are appearing in the question chat, so perhaps I'll go to those so that we make sure we're covered. It'd be great to hear from people as to who you are and where you're sending the question from, just so we get a sense of where the questions are coming from. So this one is firstly to Catherine, but next the same question to Nasser after that. It says that in England and Scotland, the pandemic has resulted in perhaps more attention being given to our mental health and mental well-being, and the impact that lockdown has had on all of us. Is mental well-being in Kenya being talked about more as a result of the pandemic? Perhaps Catherine first, and then over to Nasser.
Thank you very much for that question. I would want to say in the middle of the COVID storm in July in Kenya, when the numbers had risen to the highest, hopefully that we won't have a second curve, we had the Minister for Health gave the Mental Health Task Force a chance to present the report on the findings in the midst of advertisements on the COVID daily numbers. And at that point, everybody was discussing about the challenges we have in mental health. Of course, the recommendations we made that we need a specific body to be charged with the role of spearheading mental health services in the country, because as of now, you find that when all the services are lumped together with the other health services, if there is an emergency like the COVID, then a lot of attention will be moved from mental health towards other physical problems. We also discovered that from our interactions with people throughout the country that we needed to declare mental health an epidemic of a national disaster, so that we could deal with stigma the way we had done with HIV, because when we had HIV, that there was a lot of stigma. And of course, the amount of money allocated to mental health is negligible. And we also appealed for more resources. At least 250 Kenya shillings per capita per year would help improve mental health. So yes, at that time, the Minister for Health gave the task force time to give their findings. And of course, after the peak, we started seeing the glaring mental health effects of COVID. And we are now having even a petition to increase allocation to mental health. So yes, we are seeing more awareness being created on mental health. And we have many users campaigning for allocation of resources to community health volunteers and community health workers, so that we decentralize the services.
Thank you, Catherine. Nasser, can I turn that question to you as well? What about in Egypt? What's happening there? Is mental well-being, is it being talked about more? Is there more, has the pandemic drawn more of a spotlight on mental health, mental illness, or well-being generally?
Yeah. I guess these things happen on different levels, really. Yes, on the first level, there's more media, social media, recognition, talked about as a question. And that's the first one that sets in. The second one is what Catherine was just talking about. The second thing is, okay, what are we going to do about it? So let's start putting more funds into it. Let's start preparing services. Let's try supporting people who suffered, or the clinical and medical nursing staff. Finally, the last point that I was talking about is, okay, you could talk about it in the social media, you could fund the services, you could set up units for mental health support. But unless you approach the society and the community attitude towards the priority of getting mental health care, then you haven't completed the circle, you see. So I would say, if you're asking me about Egypt, I'd say number one is done. Yes, there is a lot of talk about mental health consequences of COVID-19 infections and the stress that people go through and the panic situations. not only in scientific journals, but also on social media and other media. The second step is, are services being provided? I would say possibly not 100%, we're not there yet, but there are a number of units that do offer the services. But the serious problem is number 3, is that when I suffered my own infection and I went and said, you know, I've suffered a depression after my COVID infection, a number of colleagues thought this just wasn't reasonable. You don't talk about these things, you know, you keep that to yourself. And that has to change, because if our mental health professionals can't talk about mental health problems, then what can we ask the community to do? So those are 3 different answers, but all true, I think.
Nasser, thank you so much. And also talking about the fact that you suffer from depression as a result, you know, agree there's a question about stigma coming up actually. Elaine, what about you? I mean, the same question to you in Scotland, you know, different part of the UK, but do you think there's enough of a spotlight on mental well-being and mental illness?
I think over the last few years, there's been much more publicity and acceptance of people struggling with their mental health and actually looking for mental health services. And because I work primarily with under 18s, I would say young people are ahead of the game. I think they're a generation who are loudly asking for help with their mental health. And they don't really seem to be struggling with mental health being any less important than physical health. So my main thing would be, I think that the funding and commissioning of services is still stuck in an older fashioned way of thinking, that children and young people don't struggle with their mental health, or that physical health is more important and needs to be thought about separately for all ages. I think what we're needing is more the commissioning and the thinking about services to reflect that. So we're making progress with public acceptance. I think it's now moving to commissioning and funding of services.
Thank you, Elaine. Moving on to another question here. It says to Catherine, but it might apply elsewhere, from Michael Doherty in Belfast. Thank you for saying where you're from, Michael. So Catherine says, I have made a number of visits to Strathmore University about student mental health a number of years ago. How are the university students in Nairobi managing, and are the students back at university?
Yes, all the universities at some point were doing online classes. So the face-to-face classes were closed, but from 5th of this month, the universities have been opened. But we've seen a lot of young people breaking down because for them, majority of our population is young. As you know, Africa, the median age is around 19 years of age, which for Africa might have explained why we didn't have many deaths, and hopefully that we are not still waiting for more deaths. But we had a lot of anxieties, a lot of depression, a lot of lack of sleep, and the number of young people consulting has increased in this period. And we are also seeing many of them on social media campaigning about mental health. This morning we had a discussion also on creating awareness on a national TV. So yes, we are seeing many young people. Strathmore, you mentioned Strathmore University. Yes, they have mental health services, but it becomes a challenge for those who have no insurance, and they have to be paid, the services have to be paid by their family members. Yes, so the universities are open and we are seeing more young people seeking for treatment.
Thank you, Catherine. Thank you. So here's a question for Nasser. This is picking up on the stigma comments you made earlier, Nasser. So it says that stigma has always heavily affected the Middle East. How has COVID affected patients in this respect, do you think, and especially women?
Right. Well, the answer is yes. I mean, thank you very much. That's a very good question, actually, because the answer is it's been very stressful, and there are a number of people in every community who suffer from psychological disorders of various forms, and you know, just to if someone suffered from a bipolar disorder and has been well maintained on lithium, but has had to suffer that stigma, then they're affected by the virus. Then they have an added state of having had that as well. And it is a very difficult situation. We've run a number of anti-stigma campaigns in Cairo. And it's interesting, you know, for these things, you work with media experts and people who were professional in that field. And their view was always, you can't sort of come up with a statement that's going to shock everybody. You've got to do it in stages. You've got to work on anti-stigma in what is going to be acceptable. And the same applies to mental disorders, and the same applies to COVID as well. So gradually, we've taught people that, yes, it is okay to work with somebody who's got a psychological disorder. And it's all right to get married into a family where somebody suffered from depression. And gradually, we're going to be able to tell people, look, if somebody suffered from COVID, you could possibly meet them a month later when they're negative and say hello to them. And work with them in the same room. You know, it is doable. So we have a long way to go, and the Middle East is particularly challenging, I think, on that field. I've always struggled to include service users and patients and families and you know, communities into the policy making and the depression, but that's not necessarily how the general culture goes. So yes, we're working on it.
Yes, thank you so much. I was just thinking as you were talking that one of the issues that, you know, we have talked about in the UK is how COVID has disproportionately affected those with underlying physical health conditions, but also our BAME population, so our Black, Asian, minority ethnic group. And it sort of strikes me that that is also, you know, when we think of access and coming forward with our mental health, you know, there's stigma across, isn't there? And, you know, in the UK, you know, one can look at, you know, most people from most backgrounds, actually people are still reluctant to come for help. And there is a particular issue around some of our BAME, I guess, patients or people from those backgrounds coming forward for help. And there's a risk that they won't come forward for their mental health needs as a result of COVID as well. And that's definitely something, you know, we want to be able to change.
Yes, you know, Trudi, sorry, but you know, when I started telling you about the denial that I went through at the beginning, all those psychological processes will have an impact on the spread of the condition. You see, if the more we destigmatize the COVID infections, the more likely people will come out and ask for help. If we stop sending police escorts behind them, they're more likely to come and accept help. You see. And therefore, less infections, more access to information, a lot of more precautions. So I think it will have an impact. Yes.
Thank you. So scrolling down, quite a few questions appearing now, which is absolutely fantastic. A question here saying, I saw a dreadful increase in morbidity and severity in the period right after the lockdown ended locally. You know, something I hadn't seen in 3 years. It wasn't just affective disorders, anxiety or stress related problems, but also mania, psychosis, that I think would have been otherwise picked up much sooner. Has this occurred in the locations that, you know, that you work in? Perhaps Catherine and, you know, maybe Elaine. Catherine first, yes. And then Elaine, and then Nasser.
Yes. As I had alluded to before, when we closed, reduced the hospital accessibility to hospitals, especially public hospitals, many people were not accessing their treatment. And so the ones who ended up coming were the severe ones who needed admission. And for sure, that clearly showed that if there was no discontinuation, probably they would not have been needing admission, they would have been treated as an outpatient. Yes, in Kenya, Nairobi, we had high rates of admissions during COVID time, and even post-COVID, we are seeing increased numbers where people wait for very long and they come to hospital when they are needing admission, when they could have been treated as an outpatient.
Thanks, Catherine. Elaine?
Yes, we certainly have had late presentations with children, young people coming with more severe being more unwell with, for example, as I say, psychosis or eating disorders or severe anxiety and depression. But one of the major aspects of the lockdown was the closure of schools. And I think as a society, we have recognized so much how important schools are for children and young people. And education and academic work is only part of it. So we're more aware than ever that school provides a structure, a routine, often a nurturing place for children and young people to go. So a lot of children really struggle with schools being off, and we're very happy to get back into schools. But some children who struggle with school, for example, if they have a neurodevelopmental disorder like autism, found the lockdown quite comfortable. And they were, when we phoned them, they'd say, no, this suits me fine, I'm at home, I don't need to go out. But when schools returned, we have seen a huge uptick in presentations of children who are finding the return to school much more difficult. And I think the anxiety about contracting COVID is an additional burden to what day-to-day life is like for them.
That's brilliant, Elaine, thank you. That sort of covered another question that was for you around the impacts on children. Nasser, what about yourself? What about, you know, the types of presentations and the severity of presentations of mental illness?
There's been an increase, there's no doubt, and there's been difficulties in following up people who were on maintenance therapy or psychotherapy or lithium testing. And so there's been an increase, but there's also not just an increase in number, there's a qualitative change as well. You know, I've been in practice for some 40 years, but I've taken over a practice from family. My grandfather was a psychiatrist, but in the early 20th century, when my grandfather was working, doctors, you know what, doctors smoked a lot. And he would offer his clients a cigarette, and he would have a cigarette, and they'd light it with a lighter, and there was sharing. Now, obviously, that's gone, and then gradually, clinicians would have a drink or a cup of coffee together, or offer them tea and biscuits when they come in for the afternoon. So that's gone. Now we wear masks and you know, disinfect our hands when we go into before a session, if there is a face-to-face session, if there is such thing. And I think that has changed. And what I have seen, if you're asking me what has increased with that, is OCD. It's all becoming much more cleanliness, nearly obsessive concern, and even when families come in together, showing care within the family will often have to do, be careful, grandma, don't touch this, because you could catch the virus. This is how we show concern. So I think OCD is definitely on the increase, if you ask me.
Thank you. Moving on, so we're back to stigma. Stigma's it's a big topic here. Just saying, so good to hear Nasser talking about stigma of mental health workers, talking about their own mental health struggles. Do the speakers have any tips for helping professionals take care of themselves? Important all the time, but especially when working in the middle of a pandemic. Catherine, can maybe come to you first on that one?
Yes, in Kenya and specifically where I work, I found approaching a colleague specifically to discuss about your mental health needs very helpful. It's still very hard for people to come out and say, yes, I'm a psychiatrist and I'm struggling with depression. But when you approach individuals, then you're able to get care. The Kenya Medical Association, which is the umbrella association for all doctors, started an online counseling service for Physician Heal Thyself, and that was very helpful. You could call and talk to a psychologist who then could refer you to a psychiatrist privately, and that really helped healthcare workers. So we're still facing a lot of stigma, but I applaud Dr. Loza for coming out and saying, yes, I'm a psychiatrist and I've suffered from depression, because we know we are not immune to depression, and we should be able to come out, and our patients should not look at us like we are lesser doctors because we are suffering. They should look at it like we will understand what they are going through better now that we've gone through it.
Yes, Catherine, thank you. Elaine, any tips from yourself?
Well, yes, I was just reflecting a little bit. I work in a children's hospital, and at least every month or two, a pediatric colleague will come and ask for advice about their children because they're worried about their mental health. And it's just part and parcel of the work. And I rarely would have colleagues asking me for advice about themselves, but it is interesting, and through those discussions, they then begin to speak much more openly about their own mental health. So I do think in the UK, there's a generational shift here. I do think younger people are more open to acknowledging that they might be struggling. I think in our profession, it's still quite difficult to say, I'm a psychiatrist and I'm struggling with my mental health, although there are some really good services set up for supporting doctors, and the RC Psych has been really helpful. And I think what's really good is having arrangements like mentoring for new consultants or trainees and supporting each other through our peer groups, which is trying to maybe prevent things becoming more and more difficult. But I think it's a work in progress. When I was thinking about my own mental health, maybe it's because I'm a liaison psychiatrist that I tend to think about it connected with my physical well-being. And when I think about things that I know really help me, as well as being with family and friends, it's usually physical activity. It's usually about getting away and moving and being outside. And I think that's partly because the work we do involves sitting a lot and also exposing ourselves to other people's emotions. That's our job, isn't it? To understand them, to maybe help work with people and feed them back in a way that feels more manageable. So I think we soak up a lot during our working day. And I find that the best release is doing something active. And one of the things that I'm missing out is our community choir, which I'm not a good singer at all, but usually on a Monday evening, I join with people and we have such good fun singing. And there's something about that shared pleasure, which I'm really missing. So I think we're having to just choose what we can get to do during this pandemic.
Thanks, Elaine. I was just thinking as we were talking that, you know, for professionals who, you know, looking after patients and others has been really, really tough, hasn't it? And, you know, at the start of the pandemic, actually, you know, in our organization and others, and our learning from Wuhan was, you know, was around having rest and recharge hubs in hospitals where actually there was, you know, for a period, food was free. We could, you know, people could go and rest, meet up. It was social distance meeting up. That was really good. But of course, that's all gone now. But actually, I've been, you know, not surprised, but you know, it has been surprising how much stigma there still has been. That people have gone off sick, for example, from work, a whole variety of stuff, whether it's doctors, nurses, other colleagues, and they've, you know, felt really stigmatized about talking about their mental health. So I think there has to be, I feel like there still has to be a huge cultural shift in the healthcare in professions, you know, across the world, that actually is health professionals, whether we're nurses or doctors, we're able to talk about our mental health. I think that's another big shift that needs to happen. And I mean, doctors are very, very slow in asking for help themselves usually. And that's not, you know, that's really not a good thing. So maybe that's something we can do collectively, and perhaps that's something we, you know, we can do more from the college to help that culture along. So that's, I guess, if there's a tip, I think the tip is around trying to shift that culture. And you know, we moved into a world of, you know, virtual working, and even doing sort of shared activities in a virtual way, whether it's a shared cup of tea or a, you know, even though we might not be able to meet with our colleagues and professionals in quite the same way, but making that opportunity to do something fun rather than a Zoom meeting or a Microsoft meeting, which is just work related the whole time. Really challenging though. Nasser, did you give some tips locally yes, you did, didn't you? Did you give some tips?
Be more open about it.
Tips for...
Yeah, I mean, it's involving, again, you know, people who've been through the disorder are best equipped to talk about it. So I've always tried to make sure that the policymakers involve service users and ask them, how does it feel? How could we reduce that stress you've been through, how can we reduce the stigma? And I think we're able to do that. It used to be that if one suffered from a psychological disorder, then you're discredited. Then obviously you're unwell. Then we can't trust what you say is the answer. So I'm pleased to see that's changing. You know, there's much more place today for service users in general, and in the field of COVID-19, the experience of people who've been through it is of course invaluable. It's very important. So we're getting there.
There's plenty to do, isn't there? So moving on to, so you touched on policy, Nasser, didn't you? So there's a question here which is about policy and really asking the panel, what policy changes might we see as a result of this, and what changes need to be made to help patients? Elaine, do you want to, what policy changes would you like to see, and what changes for patients would you like to see? Perhaps if you kick off.
Yes, I'm allowed to have two. One would be that all our physical health is never considered without paying attention to our mental health. And that includes people who have had COVID or who've had fallout as a result of the pandemic. And I guess the other policy change would be seeing investing in children and young people's services as a priority. I'm a bit concerned that we've been spending an awful lot of money on having to manage the pandemic for very good reason. And I hope we don't come out and just have a poorer version of what we had before, thinking the same old way. And I hope we come out thinking about how we're going to make real differences in everyone's life. And one of the answers, I think, is about investing heavily. And I think you'll be pleased to hear, Trudi, that there's very good developments with perinatal and infant mental health here in Scotland starting. And I think, why not start in the very beginning and give children the best start? So that would be my two wishes.
That's brilliant. Well, I would wholeheartedly support that for very obvious reasons. Brilliant, thank you. Catherine, what about yourself in Kenya? What would you like to see in terms of sort of significant policy or impact on patients? What will make a difference?
Yes, starting with amending some laws which are almost everywhere in Africa, especially the fact that suicide is still a criminal offense, or attempting suicide is a criminal offense. The task force on mental health in Kenya had recommended that we need to repeal some of those laws. And of course, I had mentioned earlier, we had advocated for having a specific body dealing with mental health services in Kenya, both for promotion of mental health, preventing mental illnesses, and treatment of mental illnesses, so that they are not lumped together with all the physical health and other health services, because then whenever there's a competing emergency, then mental health is left behind. And of course, I'd mentioned increment of allocation to mental health. Currently, we are at around 20 Kenyan shillings per capita, and we would want it raised to about 250 Kenyan shillings. And of course, I'd said in Kenya where we are still a long way to go. We would want mental health declared as an epidemic, as a national disaster. And we hope if that approach could be taken, we could actually end up killing the stigma the way we did for HIV, and many people would be able to access the services. Yes.
That's really interesting. Do you think the HIV stigma has been killed? It was interesting to you. And how long did that take? And
it took a while. From 1998 is when it was declared a national disaster. I wouldn't say we've completely removed, killed the stigma, but it has greatly reduced because when it started, when you are known to have HIV, nobody would get close to you. But now people are even getting married and having children because CDC has declared that when you have you're on ARVs for a long time, then your viral load is almost nil. So the stigma has died, but when it started in 1980s, there was a lot of stigma. So we wanted to learn from that experience, and the National Mental Health Task Force recommended that if we could declare it as a national disaster, then we could reduce the stigma, and we could mobilize resources both nationally and internationally to help deal with the mental health crisis.
That's brilliant. Thank you, Catherine. And Nasser, what about you? If you could go to your politicians and have two asks or 2 or 3 requests of them, what would you ask for in this area?
Well, what Catherine has just said is music to my ears, really. It's such an important message to decriminalize suicide or suicidal attempts or intentions. That is important. The experience of HIV is very useful. But because I've been in practice, as I say, for 40 years, that was long before they had electronic and digital data storage. So whenever there was a policy or a new legislation, one actually had to keep a hard copy of it. And I have a photograph somewhere of the storeroom where we kept all those policies, thousands of policies. Most of them people haven't really read. So I think if we're going to ask our politicians to come up with a new policy, we need to make sure there's a strong community participation and awareness. Otherwise, it'll end up on the shelf like many policies I've seen in my lifetime. So I would argue that for every pound, dollar, or shilling we're going to spend on policy changes, there needs to be 10 pounds spent on community participation and awareness as to the need of that, you see. If you make suicide no longer a crime, but the community believes it is, you're not moving forward. So this is important. But to go back to the COVID situation, I would push more for policies relaxing the anxiety around having a family member who's positive or a colleague at work who's positive, and reducing stigma is an important message there. So don't close every office that's had one case that's positive. No, we allow people to go to work or work online, or do it whichever way. So that's what I'd like to see. That's where my dreams lie.
That's wonderful, thank you. And I'm just spotting that we've only got a minute and a half left, I think. Any final words from everybody? Is there anything, do you want to do a sort of a final 10 seconds each about, I guess, where you'd like to see mental health and COVID going? I mean, I personally would love to see more of a spotlight on, I don't think there is enough, and I think we need to really be driving this more. I'm really concerned about rates of suicide that we're seeing that are gradually, we're not seeing the full story and the full mental health impact of this. I'm worried that people with a serious mental illness can't use telepsychiatry because they actually can't access, this is in the UK, they can't actually access the kit, if you like, the online setup, and older adults can't do it. So, not everyone can access that. So last 10 seconds each from Elaine, Catherine and Nasser. Elaine, you first.
I guess as a college, what I would really like us to be getting the message out is not just that it's okay not to be okay and try and break down stigma, but give out that really clear message that we have really good effective treatments for mental health disorders. I sometimes think that can get lost when people are talking about the overwhelming wave of mental health difficulties. So yeah, we've got good treatments.
Thank you. Catherine, 10 seconds or 5,
yes.
Will you?
Yes, for Kenya and Africa, it was a challenge that because we have a lot of mobile telephone penetration, we need to utilize it more to reach out to our patients. And for schools in Kenya, our schools are not yet fully open since March. We've seen increase of teenage pregnancies. We've seen increase of depression and substance use among children. So it's very important that the children are engaged, and we hopefully that by the end of the year, all schools will be able to open so that children can be engaged. Thank you.
Thank you. Nasser, one final comment.
1 second. Yes, reducing stigma is done by the consumer service users. It's all very well having a psychiatrist come out and say, I've suffered from my depression after COVID. It would be even better if you had a politician who had more fame than the psychiatrist. Probably an actor or actress would have more fame, but what tops it all, of course, is football players. If you get one of the famous football players to come up and say, I've suffered my depression after COVID, that would have an impact. So there we are.
Brilliant, thank you. And there's a final comment around really perhaps getting into schools to tackle the whole issue of stigma and mental health and getting in, getting people to understand early. But Elaine, as you said, our younger generation are starting to be more open about this. So look, so can we, I think we're just a minute over, so can I thank you all, Elaine, Catherine and Nasser, for taking part in this discussion. And can I thank those that have organised the webinar conference. Thank you so much for everyone at the college. And finally, thank you for those who have asked and posted questions, and for those who are listening into this. Look after yourselves, and if there are ideas about what you think the college ought to be doing to support the mental health conversation in COVID, please do also let us know. Thank you very much, and we'll close.
Thank you very much.